Thank you, sir. I am Kamal Biswas from Bangladesh. I work mainly for health policy planning and health systems. Currently, I'm working for Urban Primary Healthcare Project for monitoring and evaluation of this project. So my study is based on the data of this project. So let me tell a little about this project. It's an innovative project of Bangladesh government. They introduced this project, and 11 cities and 11 cities under the local government ministry. The catchment population is, total catchment population is about 10 million. And they approach, the innovative is, the approach is very different. It's public-private partnership, service delivery is contracted out to NGOs. Stewardship roles is the responsibility of the ministry. And management training, all these are contracted. Even this monitoring and evaluation, we are doing. The HLSP is a UK-based firm. They do this monitoring, and I am actually an employee of this firm. So the core policy, I told that these are the approaches, and like many other projects, this is a focus for the poor. 30% of each services must reach the poor. This is the one of the important policy objectives. So when we are employed for this monitoring, actually 2 years have passed. So project started 2005, but we started monitoring and evaluation from 2007. So there is a gap actually. So this gap actually created an opportunity for comparing what happened before and what happened after monitoring. And this sort of project, that is urban slum areas, don't have many good hospitals for the poor. So these sort of poor women can have access to these sort of clinics, urban clinics, where they can have normal delivery, including cesarean operations, free of cost if they are entitled, they have entitlement card. I have gone through these pages. The objective of the study, as I mentioned, it is the assessment of the situation coverage of institutional delivery for the poor over a period of 2005 to 9. And also try to find out what is helping. Method is we actually analyze the HMIS data, service data. We do a monitoring every 6 months. So data quality is controlled through that monitoring visit. So the findings, you see, there are 11 partnership areas in Dhaka City Corporation. Here you see each line represents one of these partnership area hospital deliveries. % of the poor delivered in this hospital. You see, it's okay. You see that 2005, it was actually less than 2%. Less than 2% of the poor women delivered in these hospitals. But it is increasing up after 2007. It is increasing. These are 10 clinics in Dhaka City Corporation. And it reached up to, on an average, it reached up to 28.75, which is not 30%, but it's near to 30%. And the same way, in other cities and municipalities, these were the same findings almost. And cities and municipalities, the delivery was increasing for the poor. So what is the learning? Learning is the pro-poor policy doesn't itself work. You have to monitor it from the very beginning. If you don't monitor, there are a lot of bottlenecks that these opportunities for the poor you created in the options, in the policies, in the project strategy and resources, but it will not reach. We have seen that there was a lot of bottlenecks. Say there was a survey for identifying the poor from the very beginning. They did the survey, but they never disseminated these survey findings. Poor are identified, but they are not given the cards. Many are given, but the distribution was never complete. Even after 2 years, we found that many NGOs, many clinics retaining their cards, they say we are distributing. Why is this? This happened from the negligence, was not a kind of just inattentiveness. It was, there was a policy contradiction. In this project, there is a policy, if you you must give 30% of all services to the poor. There is another incentives policy. If there is user fees, the NGOs can retain these user fees if they go beyond the income generation target. They have income generation target. If they go beyond this target, they will get this 20% of the exceeded amount. So there is incentives for earning money, not giving the service to the poor. So that is why, from the very beginning, there was a lot of bottlenecks created automatically, so the poor are not coming to these clinics. So our professional monitoring actually helped. Why I say professional monitoring? Because these clinics, these city corporations has itself a healthy department, and they have a dedicated monitoring officer for these clinics. They are working from the very beginning. It didn't help. They couldn't find where is the bottlenecks. The NGOs are presenting in monthly meeting that we have achieved this and this service, but ultimately we found that the expensive services like delivery and cesarean operation, these are not happening for the poor. So this is all what I want to talk. Thank you very much, and thank you for inviting me to these occasions. Thank you.
This was only to say you had